So I'd like to welcome everyone to today's webinar. Folks joining us. A chat box, we have a pre-survey that we'd like you to be able to fill out for some research purposes that we're doing. So if you could take a minute to do that. But again, would like to welcome you all here this afternoon. My name is Ann Daggett. I'm a licensed clinical social worker working with Cornerstone Whole Healthcare Organization. And in partnership with Pfizer, we are helping to disseminate some information for primary care clinics and teams in those clinics around critical stress incident management. So here with us today is Dr. Dan Casey. I'm going to turn it over to Dr. Casey. Thanks for joining us.
Thank you, Ann, and thank everybody for attending. I'm going to give you an hour overview of a 16-hour course, more or less, identifying what CISM is, how it works, give you a little background on it. Be a little redundancy because I'll start with some stuff that I'll end with, kind of wrapping it all up. So my background, just before we get started, I was 25 years a wildland firefighter, and that time I was burned over a few times, lost a buddy in the fire line. Caused me to go back to school, and I was back because while I was in the Air Force, I had time to, between runs to Nam, to get some college, and so I got a bachelor's degree, and that led into a master's degree, and that led into a doctorate, and so I've been doing this work since 1987. I've been doing Green Cross since 1999, and I'll get into both of those as we go through the hour. We're here to talk about critical incident stress management, CISM. Comprehensive, integrated, systematic, multi-component approach to crisis and disaster intervention. I tried to get rid of that transfer between slides, but I haven't figured out how. So the objectives of this course, this hour that we're here, I want you to know the key crisis stress terms and concepts, what they call it and what it does. We'll explain critical incident stress management, how it came to be and what it's doing in the world. We're going to talk about the 3 R's of crisis work: resistance, resiliency, and recovery. I have listed, and just this slide program that you will take will have the components of CISM, the 4 main interventions processes that we do. I would explain informal versus interactive groups, informational, I mean. So some of it we talk, and some of it they talk and we talk. Don't by any means think that because you've taken this course, you can go out and do a debriefing, please. You need to get into the in-depth and practice it enough with a trained trainer that can identify what works and what doesn't, and so on. The core elements of CISM. Let's talk a little bit about where CISM came from. Dr. Jeffrey Mitchell did his bachelor's, master's, and doctorate at the University of Maryland while he was a paramedic firefighter. And during that time, he had a lot of things going on in his chosen field, and thought there had to be a way to help people do this. And so his doctorate dissertation was identifying CISM. And his advisor through all that was a Dr. George Everly. And between the two of them, they put together CISM as it is today. And it's worldwide, and it's well known, practiced on every continent for sure, in a lot of countries. Actually, the caveat was in 2009, the United Nations accepted CISM as its main intervention process around the world. And so we had to change a few names because of the wording that they used and we used, but it's that good of stuff. It's that good of information. So the core elements of it are taking a look, identifying what's there: surveillance, assessment, triage. listening skills. The SAFER model is one of the individual crisis intervention models, the intervention crisis intervention model for CISM. We'll do some assessment and planning. 2/3 of what we do is getting it ready to do it. So we do informational group processes. That's called as crisis management briefings. Interactive group processes. We do defusing, which are small group debriefings, small group interventions done during or immediately following an event. We talked about the resiliency, resistance, recovery plan. That's when we come in to help a community. The 3 R's is what we work from. And this is right out of the workbook. Identifying what it is and where it does, who does it, and so on. So the first thing I've got here is RIT, that demobilization. This is rest, information, transition services, it means. When we, a CISM team deploys to a given organization, outfit, whatever, say like the floods that we have in Western Minnesota every year when we deploy, we set up our crisis response team, and as groups that are working on, say, law enforcement, fire, EMS, whatever their work is, they're coming in to help. When they leave, we do a RIT. We do a 30-minute total intervention process where I'll just go do the what, when, where, who, and so on. You know, where, you know, when is after shift, when their shift is done. So they've checked in and worked all day, they're going home. It's 2 groups of emergency workers, and it can be more than one group. Just a size of 20 to 30 is comfortable. There's 2 steps to it. The demob is, one is sharing information, letting them know what else went on in the world while they were doing their work. And the second piece of it is telling them some of the things they'll probably expect to experience because of what they've been doing and what they've been through. Also, the part of that second step is get them to rest. They're leaving now, they're going home. So what we do is we talk a bit, and then we intermingle with them while they sit in the coffee shop and have some sugar and caffeine and head for home. Provided by a crisis team. It doesn't need a mental health, but if we do have one, it just helps. It typically takes a half an hour at the most. And if it's followed up by anything, it's followed up by a debriefing. And this is very typical. Whoever's in charge of this debriefing group will have a contact name or number that when that group leaves, they'll have. And if they think they're having a hard time with it or the person wants any more help, they'll call back and forth. And we'll do a debriefing if we need to. And we'll get into what that is. The second intervention process that we do, and we're doing more and more of these all the time, is a crisis management briefing. And this is a one-way information process done anytime to anywhere for anything that's happening. In fact, the last time I was working your country, I was called from into Coeur d'Alene because there was a 2-year-old missing. And they had 100, 150 people out searching, and when they were done, the sheriff didn't know what to do, so he called my CISM person there and said, what do we do? And she said, we'll do a crisis management briefing. And so the only place they could do it was at the baseball field, so she got out on the mound and they were sitting in the bleachers, and she did a crisis management briefing. Now, who it's done to is anybody at any time and as many as they want. It has 4 steps to it. The getting them together and then telling them, verifying what they've been through, telling them what to do and how to do it, and making sure they've got some tools to go home with. I'll get into this again, each of these more in depth, so I'm just kind of skipping through them right now. It's provided by various team members or whatever group. If it's doing in the school, has a school-based intervention process, the superintendent will open the program and so on. No matter size the group, if it's 3 or 300, about an hour and a half total is all we need to do a CMB. Usually a lot less than that. And it's followed up by assessment, and then if assessing whether we need to do more or what else we need to do. The third thing, and this is a small group intervention that I started talking about, the defusing, is a 3-step process done during an event up to 12 hours after. It just takes the hum off right away. If you had this bad call and you're putting your gear back together, you're ready to go again. We're going to do a defusing just to help you process what you brought into the meeting. Small groups. The largest I've ever done was like 26 or 7, and that was when there was a death of one of their own. 3 steps is just sharing the information, letting them know what we're doing, having them talk about it, and then telling them how they're going to be experiencing and what's going to be normal and what's maybe not going to be normal. And it takes a half an hour typically for a group of 20. It's followed by a debriefing probably 3 to 5 days later. The debriefing is the granddaddy. This is the 7-step process where we set people down in a circle and everybody tells their story all the way through it. So it says small groups. The largest I would want to do is say 25 or so, simply for time's sake, because if we got 10, we're going to get it done in an hour. If we got 20, it's going to take 2 hours. And if we got over 30, it can take 3 or 4 hours. So it's a 7-step process, and I'll take you through them individually as we go farther on. But it's just getting them there, telling them what to expect, asking what's the worst part of it for them, ask how they're reacting, and then we do some teaching and wrap it up for them. Provided by a team member. And we want, if it's a fire group, we want fire peers, law enforcement, nurse, whatever the correct peers, and we have them on the team. This is the only one of the 4 interventions that we say we need a mental health professional at. Because we're taking people back through the scene, back through their worst feelings about it, and we see some dissociation, not every time, but often enough that we really need a mental health professional on the team trained in crisis management. Typical debriefing takes 2 to 3 hours and is followed by referrals and maybe another debriefing in the future. Now, definitions, word definitions as we go. Crisis, an acute emotional reaction to some powerful stimulus or demand. So crisis isn't the event, crisis is the reaction to the event. How do you know it's a crisis? It does things like disrupts your state of psychological balance. You're out of whack if you use wax. Your usual coping mechanisms fail. The way you typically get through something like this isn't working for you. To the point where you see you're distressed or even impaired or maybe even dysfunctional. Things you can't do anything right now because of this event that you've been through. And Kaplan came up with this in '94. He's identified crisis for what it is today. Recognized crisis as Dr. Mitchell put together CISM was based on Daryl Kaplan's characteristics of crisis. Crisis and stress. When a person has an emotional crisis, there's also a state of mental and psychological arousal. Stress goes along with the state of emotional turmoil. So you've got the crisis, and the stress is the reaction to the crisis. We live in stress throughout our life, right? Every day. You're stressed or you didn't get up this morning. Everybody's stressed to a certain degree all the time. But we've learned how to balance between good stress and bad stress, and we can live with that as we go. Stress is a state of arousal from mild to extreme. It helps us to stay healthy. There's 132 chemicals mixed in our body to make sure we survive the event. The stress aroused from that keeps us on, kicks it all in, makes it work for us. So you can have stress even if you have no crisis, but you can never have a crisis without stress. I guarantee that. How does it relate to COVID as we're talking about? Stressful times full of change and uncertainty, you bet. Who knows what's going to happen, who's going to get it, where it's going to end, and so on. What do we see? Things like schools are canceled. Minnesota's talking probably going to start in-home schooling for 80% of the state. People are out of work. Our unemployment rate has quadrupled from when before this happened. Few million people out of work in the state. Vacations, graduations, weddings were either canceled or really postponed, or it became a one-on-one thing instead of the crowd. Social interaction is certainly limited. Can't go anywhere without a mask here in our state. Go to church, you're sitting two people, 6 feet between two people, whatever. Stock market crashed, and thanks to Trump, it's still alive and going. People are contagious but asymptomatic, so you don't know if anybody's got it until you've probably been exposed to everybody. People are sick and dying. Brings us to critical incident stress, identified as acute emotional, cognitive, and physical reaction. So thinking and doing results from an exposure to a powerful, threatening, grotesque stimulus or overwhelming demand or circumstance. So whatever it is, it's really out of the ordinary and it's really overwhelming. That's what we're saying makes a critical incident. In crisis intervention, the work that we do with this, it's temporary, active, and supportive entry into the situation of an individual or a group. So crisis intervention is done many times on site if it's ongoing for a while. More often right after the event, we're identifying critical crisis intervention and what needs to be done. Why do we do CISM with COVID? Because frontline responders, trauma, witnessing so many illness and death have lasting effects for many. Just worked on a physician suicide, overwhelmed to the point of death with all the people that were dying around him and no control, no help. These are, by the way, all these quotes are listed in the back of this slide program for you to look up if you like. Why are we doing CISM during COVID? This was one slide ahead. Tragic death by suicide of an emergency department physician who had been caring for COVID people in New York City underscores the huge psychological impact of the pandemic, which will linger long, long after the virus is gone. Back to critical incident stress management, what we're here to talk about. By this definition, an organized approach to crisis intervention. Package of crisis intervention techniques. We do defusings, debriefings, and so on. Includes large group, small group, and individual intervention processes. CISM is a subset of crisis intervention and shares directly in the history, theory, principles, practices, goals, and techniques of crisis intervention. And I'm not going to read every word on every slide as we go through, but I'm catching up to that now. Okay. Who provides crisis intervention? Anybody that works with people. Police, firefighters, medical staff, hospital, EMS, military, federal agency, communications folks, community volunteers, school personnel, mental health professionals to and in, clergy, chaplains, and others. If you're on site and something happens, you're a provider. Goals of crisis intervention specifically are to first, reduce emotional tension. Have them identify, or you identify how it's bothering them and let them know that that's normal. Normalize their reactions, which stabilizes them. They just typically need somebody to talk to. So when we're doing our crisis intervention one-on-ones, we're on site. We'll have handouts in one hand and a bottle of water in the other, and offer them water and ask if they want to talk, and have them. And if most of them are having a problem, they're really happy to talk. They really like to just remove it from their sense and talking. Help them to mobilize the personal resource that they have to help them process it. And the other one is to mitigate the impact of the traumatic event totally. So as much as we can. So how do we do that? We're going to normalize the reactions and help them to a recovery process that normalizes things. Restore them to adaptive functioning, be able to do at least as good as they did before this event happens. We also find it enhances unit cohesion. An organization that's been through an event altogether, the cohesion is better. They're working better, they get along better, they perform as a homogeneous group. The other goals are identify people who may need more help than we're able to give. So if we're on site and we're doing crisis intervention, we're worked with 8 people, and maybe one of those is really overwhelmed to the point where they can't really talk and walk at the same time. We have to make a decision on what we do with that person. For definitions, stressor is the stimulus that causes or initiates a stress response. Something going on, some event or some news that you get that kicks in your stress reactions, makes you worry about it, helps you process it. Stressor versus stress response. The event is the stressor. No matter what it is, that's what's causing our stress. Stress, by definition, what Selye himself says, it's the non-specific response of the body to any demand placed upon it. So if you didn't get up this morning, if you got up this morning, you were stressed. You might have your toothbrush broke, you were stressed. You missed breakfast, you were stressed. Whatever it is, it's arousal based on a stimulus, on some event that happened. Difference between stress and the stressor and stress response. Stress is a combination of neurologic, neuroendocrine, and endocrine arousal response mechanisms. So our whole body is reacted to it. Our mind, our body, our senses, everything's affected by the stress. It can alter every organ and function in the human body. Accelerates the aging process, especially if you work really long hours. I guarantee you after a few days that you just, in mind, you've picked up 20 years. Stress equals arousal. Arousal is stress, stress is arousal. Selye, the father of stress as we know it, was an Austrian doctor, worked in Canada some 30-some years, wrote 1,700 articles on it, 37 books on stress. He's the one that came up with stress, defining stress as it is today. There's 3, the general adaptation syndrome with stress is alarm, which is when the event happens or when we realize what's happening, what we're thinking, feeling, emotional feelings. Resistance is when we're trying to cope with whatever the event is, and exhaustion is when we have been at it so long that our sources and inner sources are depleted and we're not able to process it. Hans Selye was the father of stress, as I said. They tell the story. He was scheduled to do a discussion on stress to the World Health Organization in Switzerland, and he was telling his one of the classes he taught about it, and he starts talking about it, and they said it was an engineering class, and he started talking about the stress, and they said, you know, you named it wrong. Stress is the strength of a bridge. Strain is the weakness. You should have called it strain. Selye says, well, I called it stress, and stress is what it's going to be, and that's what it is in the world today. The main types of stress we see. Eustress is good stress. That's positive stress. That's a wedding, marriage, new baby, things like that. All good stressors, good events, but stressors. Positive events, still stressful. Distress is all the rest of stress. That's missing a payment, to losing your car, to getting robbed, to getting shot, to any of the bad things that happen in our life is distress. Stress itself isn't dangerous. I mean, as our body goes into stress response so that we survive. So it isn't usually that dangerous, unless it is prolonged or intense. 9/11, 2,700 people die. That stress, prolonged, intense. We worked there on the ground for 3 years. My organization did, in and out, working with folks as they were cleaning it up. Back to COVID, persistence of the pandemic. The crisis is shaping up to be a marathon, not a sprint. Self-care will remain a critical and ongoing issue. We're in this all together. So we need to, just verifying, we really need to take care of ourselves at this time. We need to help others, but we need to make sure we're okay too. Cumulative stress. Stress that builds up over time. Burnout is one of the stress terms that we typically use talking about cumulative stress. By definition, it's unmitigated stress arousal that builds up over time. So there's stress that we've been involved in and that we haven't figured out a way to control. The 3 phases of cumulative stress. Again, back to Selye: arousal, conservation, and exhaustion. If you've got stress and you've been aroused by it and you're trying to work your way through it and you don't get through it, that's cumulative stress, and that's a dangerous stress. Target organs. Jay Lindy came up with this in the 60s. That part of the body or mind that is target of stress and which develops signs and symptoms of overarousal. Now, if there's 30 of you listening to this and I'd ask the question, what's your target organ? How do you know what part of your body tells you you're under stress? Well, here are a myriad of things. I get a pain in the back of my neck. My heart starts racing. I can't think right. All of these are typical reactions, and that whatever yours is, that's the target organ. That your body, your mind has decided. Your body will tell you when things are going bad or changing. So everybody's is different. Maybe you've got the same as a few others, but trauma, by definition, any event outside of the realm of usual human experience. Also, the person that's experiencing finds it markedly distressing and may be scared, helpless, horrified, any one of the trauma reactions. Traumatic stress is the most intense form of distress. It's more intense than any other stress that we experience. And it goes through, or we pick it up from thinking, with cognitive, physical, emotional, spiritual, behavioral. All of the five senses are affected by traumatic stress to some degree. Some people with one more than others, and so on. PTS, post-traumatic stress, is critical incident stress. Normal response in normal healthy people after an abnormal event. It typically temporarily overwhelms our coping mechanisms, and we have reactions from that. Critical incident stress is normal. Everybody goes through it. If you've been through an event out of the realm of your norms, that's a crisis incident. Most of them we can get through, 80, 90% of them, we can walk back out and be okay. It becomes dangerous to health only when it's not resolved, when you can't find a way for it or you can't get help for it. Post-traumatic stress. PTSD, I won't spend much time here other than to say, if whatever you're suffering, you've gone on long enough, it develops into a mental health disorder. May turn into one or more psychological conditions that interfere with normal life functions. That's what DSM-5, that's how DSM-5 puts it. Post-traumatic stress disorder. Other things we see arising, resulting from trauma. Substance abuse, and I can give you stories on all of these, but I won't because I don't have the time. But substance abuse, withdrawal, this person's the outgoing person and now they're shut down. Depressing, the worse it is, the more depressed people get. Brief psychotic reactions, we might see that. They just kind of go off on their own and do things that you wouldn't expect them to do or that are not normal for them to do. You might see panic attacks, people really affected by the incident to the point where they're having an attack. Might lead to panic disorder, but actually DSM-5 would say this is a problem. This needs work done. We see changes in personality. We see a lot of loss in self-confidence. I couldn't get through that. I wonder what else I can't get through. Increased anxiety and irritability. So if you work in a high-stress job, these are the things you might look for or expect to see or can recognize in folks. Trauma membrane. It's an interesting concept that Lindy, 1960, come out with this at first. We've been talked about and everybody's recognized, identifying it works. After trauma, people form a trauma membrane around themselves that insulates them from additional trauma. Over time, it may block out appropriate help as well, besides blocking out the trauma. And the only way we know to fix that is early intervention. For instance, if I'm doing a debriefing, say law enforcement or fire, and there's some rookies and there's some 20 years, say the incident is a suicide or shooting, and the old timers will say, yeah, I don't really need to be here. This isn't bothering me. And this is before we sit down and do our debriefing. So I'll tell them about trauma membrane. There's a membrane that you don't see, but it actually builds around you. The more stress and more crisis you've been through, the thicker it gets. You've got that insulated to the point where things like this don't bother you anymore. And that's, well, it's not healthy, but that works for you. A lot of people do that. But understand, a lot of these rookies, 2-year, 3-year, 5-year working folks haven't been through this. And if you could sit through this and tell you're part of it regardless, you're going to help them process it. So, but just as you were listening, folks, trauma membrane is just if you work in trauma, you form a membrane, kind of like a liquid form that just covers you. You're insulated by it. Symptoms of traumatic stress, all of them. What we're thinking, how we're feeling emotionally, changes our behavior. We get aches and pains we don't typically get, and will certainly affect our spirituality to some degree. Either make it stronger or make it a lot less. I see already working with the COVID thing, churches are half or more empty, and I'm sure that it's going to take a few years for people to get back to where the whole crowd was before this happened, because they've got to process it, the traumatic stress from it, and so on. We'll talk about the senses for cognitive, the thinking distress first. What you see in blue is very typical. What you see in red can be dangerous. So in this case, we have sensory distortion. Things are out of whack, whatever a whack is. We have confusion, dumbing down to the point where, along with inability to concentrate, works. How many times have you, after you've been through, or maybe normal, you're walking across the floor to get something, you get halfway across and you wonder, where in the hell was I going? And you have to go back and get in doing the same thing again before your unconscious will pick it up. That's a dumbing down. Difficult decision making. The person that really, the supervisor that's been through a lot, all of a sudden really having a hard time identifying what needs to be done and how it needs to be done. Guilt, preoccupation, inability to understand their consequences, suicidal, homicidal ideation, and psychosis. All are cognitive problems that arise because of an event we've been through. Emotional distress, very common. Anxiety, irritability, anger. May see panic, vegetative depression. We just shut down. They can't do it. They're incapable of doing what they typically do. We'll see fears, phobias. Phobic avoidance is a big one. I would have had that, put that in red, because if it's 3 blocks to the grocery store, but you drive 10 blocks because you don't want to go past where that event happened, that's emotional distress and grief. Behavioral. Talked about this a little already, but impulsiveness, risk-taking, excessive eating, overuse of alcohol and drugs. The hyperstartle. If you've got a person that after a while you've been working and you have to not only stay away, maybe touch them with a 10-foot pole for the startle effect that you see from them, that's behavioral distress. Compensatory sexuality or purchasing, buying, any compulsivity. See, sleep disturbance, withdrawal, family discord. The stress of one person can throw the whole family out of whack. Crying spells, hypervigilance, as along with hyperstartle. Hypervigilance is always on the lookout, looking for something that isn't there, to worry. The 1,000-yard stare. You got that blank look, that person needs a lot of help right now. That should also be in red. Violence, antisocial behavior, physical distress. Heart races, or heart really slows down to the point where it scares you that it's going to stop. Headaches, hyperventilating, muscle spasms, psychogenic sweating. All of you have been through that. If you've been near something that happened, you're going to process that. Fatigue, exhaustion, indigestion. If there's blood in stool or sputum or vomit or urine, or if there's loss of consciousness or chest pains, time to get help. Spiritual distress. Starting to see this more now with COVID. Anger at God, loss of belief in a just world, lost sense of purpose, doubts in the resistance of a benign God, abandoned by God. There'll be some withdrawal from faith community. As we said, we're already seeing a lot of it. And it might, if it gets to hallucinations, then that should be in red again. I'd be worried about hallucinations. As your body goes through the stress response, something's happened that's out of the ordinary, your unconscious is picking it up, whether you think it or not. Your body goes into the stress response, and there's 132 chemicals mixed in your body. And I'm not going to get into all of them because it will take the rest of the talk, but the stress affects the brain just as does alcohol. So I simplified the brain to the front of the brain is reasoning part, midbrain is the emotional part, the old brain stem is the old part. So the man takes a drink, the drink takes a drink, the drink takes the man, and the first thing that's overwhelmed is the reasoning part of the brain. That's why it doesn't pay to argue with the drunk. You can't reason with the drunk because they can't reason. If they drink enough, their emotional part is overwhelmed, and all that's left is the brain stem, the liver, lights, and lungs that they run. And if they drink enough, they die. Stress works exactly as does alcohol. So you get in an event and you're overwhelmed by it, just or anybody is, and the first thing that goes is the reasoning part of the brain. They're working from their emotions. That's why it's really hard to discuss with folks where have to show them because they're working from their emotional part. And if they are overcome, if that's overcome, again, we go to the brain stem. And if that's overcome, they die. There's a chemistry of survival. And there's 3 areas of chemicals that happen. The catecholamines are the first one to talk about. This is the positive that excites the system, triggers the increased nervous system, kicks in the fight or flight. This is actually the bunch of chemicals that save us. The corticosteroids are the second area of chemicals that are affected. And their job is to moderate and control extremes of the catecholamines to keep that fight or flight in check. Herein lies one of our first problems with the chemicals, because the greater the catecholamine drive, the less corticosteroids there are. And if you're in full-blown crisis, the corticosteroids aren't there for you. They shut down. The third area of chemicals, and the one we recognize most, are the indigenous opioids. They do things like create a heightened threshold of pain. How many of you in your line of work or in your life, an event happened and you look down or it's over and you realized you're bleeding from your arm or your elbow or your leg or whatever, and you didn't notice until you looked at it. You didn't feel it. Feelings of emotion, feelings of euphoria. Sure, all of you have stories on that happening where they're really out of whack reactions that you have. For instance, yeah, I could tell you the story. My wife was killed in a car accident. My daughter and I were in a vehicle right behind her. She was going to work, and we were picking up, and then we go to the doctor, and we dropped her back off. Well, she left. We got in behind her 5 minutes. We started down the hill to get in this little town, and there's 2 vehicles, one on each side of the road. Daughter said, "Dad, that's Mom's car." And I said, "No, it ain't," but I could see it was. I pushed her down under the seat. I can feel her hair on the palm of my hand as I tell you this. This happened 30 years ago. I cruised down, but I went past her vehicle before I stopped because I didn't want daughter looking out the window. Law enforcement dude from the little town came, parked between us, went over and said, "Case, don't go there." Went over, come back, said, "Case, don't go there. What do you want to do?" And I guess I said, I should call the in-laws. I don't remember anything from him stopping until about 3 hours later. But I went to town, got to my friend's house, 6 in the morning, I had a knock on the door, told him what happened, used his phone, and then left my daughter there with her, and I went back to the accident. About a month later, I had a young fellow come in the office. He said, "Mr. Case, do you know who I am?" And I said, "Yeah, you're one of the Labrador boys from Monaga, ain't you?" And he said, "Yeah, I was the guy that gave you a ride into town the morning of your accident." So, "What do you tell me about that? What do you remember?" And so I just go back there, and I could see it now as I could see it then. I could see us getting into the car, daughter sitting in my lap. getting to my friend's house, going up the little hill to his door, and you looking at me kind of funny. I said, yeah, that was because you were singing nursery rhymes all the way into town. That was what? You were singing nursery rhymes all the way into town. Granting of emotions, feelings of euphoria. My unconscious wasn't letting me go any farther than that at the time. In fact, the next thing I remember is 3 hours later with a friend driving me home. Also see dissociation and amnesia reactions, not able to remember things or just shutting them off entirely. I have a long story that I'll shorten immensely. While on fire, I've been doing it for 25 years. After about 5 years, the state of Minnesota and feds signed a reciprocity agreement, so I spent a lot of time on Western fire duty. Ran into a little fella and worked for years with him. He's a great guy. We became great friends. We're working a fire, and he had a tree fall on him. The natives out there call it angel wings because the ponderosa pine, when it burns completely, and then when it got fire in it, when it falls down, there's no noise. So anyway, my friend gets pinned on the fire line. I can't move it. I wake up 3 hours later in the nurse's tent at fire headquarters. I walk back. They tell me I told them the whole story very calmly and plain in where it was and everything else. I don't remember any of that. My unconscious says, let's dissociate, do little amnesia. You don't need to remember that. So I'm sharing that because if you run in, people you're on site and they can't tell you what happened, they probably don't even remember it. Their unconscious has shut it off. So as crisis response teams, what do? Start out with assessment and planning. We advise on prevention curricula before we even get in there. The training we're doing, the work we're doing right here. We do crisis management briefings, defusings, debriefings, CMBs. We do a lot of classroom discussions. We do some screenings for the mental health professionals. We provide community expertise, attend funerals, and so on. What do crisis response teams need? They need community resources, hospice, clergy, mental health, nursing, mutual aid agreements with outside resources, the ability to have access to other teams to debrief their debriefers, and so on. Psychological first aid. This is one of the things that has come about to develop because of Green Cross and their psychological first aid work. It's a set of skills that help community residents care for their families, themselves, and neighbors by just making sure everybody's okay. Psychological first aid is just 3 parts to it: knowing or understanding common symptoms and responses, being a good listener, and knowing what resources are available. An event happens, we as Green Cross, as we deploy, that we do mostly psychological first aid, and that's with a bottle of water in one hand and some handouts in the other. And we're on site wherever it happened, and we're talking to people. During the fires in California, I do a lot of EMDR in my business, and I had 3 non-mental health folks that were part of my team, and we were working with FEMA, and most of those FEMA there was like a 70-person staff that had been on site for some of them 7 months, really overwhelmed. And so listening to that 100th story of losing your house and losing your friends and missing people and so on, there's a lot of them would have a hard time getting through the day. And so my group would wander and meander and get people to know who they were at Green Cross vest and everything. Or they, after the first day, they'd come up and say, my friend needs to talk to somebody. And they would bring them to me as a mental health professional in the team, and I would do a little EMDR intervention, a short EMDR intervention that in 5 minutes would help them process the emotion that's stuck on the memory and have them get back to work. So psychological first aid is that, being there for people, providing what they need, So again, most psychological first aid work is a bottle of water in one hand and some handouts in the other. Being there, talking to people, letting them know you're there to help. For staff, what does staff need to know to process and help people process strategic events, crisis events? Their program should be comprehensive. It should cover a large area. Everybody knows that it's not therapy, and the people are helping and the team. It's a support system. We're able to integrate it into any situation. We have a systematic method of doing this, and we know that system works, and so that's what we process. And staff support should provide a full support program. I work with a hospital in Sioux Falls, South Dakota. I still work with them, but they really very quickly put together a program with this. And they found that Mary, the person that runs it and has run it for 25 years, tells me that their recidivism rate, because of events, dropped to zero, simply because they put in a good staff support program. Effective staff support programs link to a wide range of resources, that medical, physical, doctoral, whatever. It should be run and staffed by peer support personnel, people that know what they're talking about. And the core elements of effective staff support: assessment. What are the circumstances? What happened? Nature and magnitude of the event, the impact on people. One of the ways we work with them, we talked about this a little earlier, the RITS, Rest Information Transition Services. People are leaving the scene after helping or do that. Crisis management briefings, we're going to do a lot of those. And I talked about them a little bit. RITS, Rest Information Services, CMBs, informational groups, works with any event. Been used in every type of intervention process or incident that happens. CMBs. The goals of CMBs are to help people process through an event, provide information, control rumors, reduce chaos. Let them know that help is available and how to go about it. There's 4 steps to it, and I said I'd go into this a little bit more, just a little bit more right now. Is step 1 is a symbol, get the participants there that are affected. Step 2, provide accurate information. Step 3, identify some of the reactions, the normal reactions that they can expect to go through because of the event. And 4, strategies for making that happen, helping them along. So in the business, CMBs, we call it AIRS because it's the 4 steps. And we do these, I probably do 3 debriefings to 1 CMB because this is a large group of information stuff, but it works. Defusings, interaction group processes provided the same day. People sitting in the circle are the ones that were fully indirectly involved. So you might have law enforcement, fire, nurses, doctors, chaplains, all sitting in through the same defusing. Three phases to it. Introduction, telling them introducing ourselves and telling them what to expect. Exploration is allowing a brief discussion, ask each person to tell their story. And information is sharing, normalizing what's going on with them, teaching them, give them some guidance on what to do and how to work. Definition of a homogeneous group. They have experienced the same traumatic event, so they don't have to work together, live together. Homogeneous group has the homogeneity is the trauma itself, the event. They have a shared history, they spent time together. The goals are to mitigate the stress, help them process it, tell them what to expect, identify some resources. Typical debriefing team is 2 people, one of them is mental health. Everybody's trained in CISD. Ground rules I'll go over very quickly. The voluntary participation, but encouraged. We're not going to take any notes, no breaks. It's not an operational critique, not an investigation, no blames, not therapy, addresses issues of confidentiality. And here's the steps of it. Introduction, lay out the ground rules, facts, who are you, what happened, thoughts. Thinking what were you thinking when you realized that it happened? Reactions, what's the worst part of the view? What's the emotion that goes with that? Symptoms, how's it affecting you? Teaching, we're going to normalize their reactions, give them some guidance and support. Reentry is wrap up confidentiality. I got one more slide I think we'll go through and then open any questions. Ground rules for CISD. Confidential, what said or stays here, we're not going to tape anything. Where we used with COVID, where I've used it, hospital staff working with COVID victim, one of theirs gets the virus and dies. The CISM team was called in to debrief the group that worked with them. And that's a very normal use for CISM. And we're going to see a lot of it with COVID. Back to our slide, the things we talked about earlier. I'm not going to cover it. For COVID, physician support line. Please write this down, 1-888-409-0141. Free mental health hotline. It was put into place in March. The first 3 weeks, they logged 3,000 minutes of call time. So it's a good organization, a good setup, and it works. Our references, as I said earlier, you got a copy of this whole program. If you're looking for more facts on anything I talked about, you'll find it in that. And that's what I have. And I have 2 minutes to go, I believe. Questions, comments?
Yes, does anyone have any questions at this point for Dr. Casey? I don't see anything in the chat box, but if anyone wants to unmute yourself and just vocalize your question, feel free to do so. All right, well, if we don't have any further questions, it looks like there's several people that are exiting the webinar today. I'd just like to thank you again for all of you attending today. And also thanks to Dr. Casey for his wonderful presentation. Please feel free to give him a call or reach out to him if you do happen to have additional questions. Thank you so much.
Absolutely. Good to go.